Look, it's Angie's face.
Hi, I know. Hugs. I haven't seen you forever, Abby.
You got
That's okay.
Good morning.
I just well no run through the case is going first, right?
Yeah, and we didn't get the template until last night, so we're gonna try to filling it in real time as he talks.
Yeah.
So he saw it, so he knows more or less what's in it. But this is a case that he was tiger texting Kevin about, so I think it'll be it's a fresh one, which is nice, right?
Yeah, I talked to Frank one day last week on the phone.
Great.
So
yeah, and I think it's a nice case of having a lot of unknowns and trying to solve some problems, and eventually it worked out with a plan that was not the one that they.
Perfect. And do we have other cases? I just wanted to think about how long the presentation should be.
We do not, but I'm hoping somebody might think of one.
And off the cuff.
He has to be off by 7:40, so it's going to be a quick.
Sounds good.
Sorry.
So, Abby, did you want to do all the cases first?
Okay, Jazz.
Let's do just the one, and then we can do your stuff, and then if there's time after, we can do another one.
Okay.
Okay, so somewhere in here. The logistics thing. Always interesting.
Okay, here we go.
Morning.
Oh, maybe not.
Good morning.
I take that back.
Morning.
Beautiful faces. Cheer me right up.
I cannot. I have no controls.
weird. You know. I found it. It was just another chat. Few more minutes. Maybe we should start with a check-in now because it's just about time and I want to make sure that we have time for Frank. All right.
Hello everyone, welcome to today's Echo Clinic. Before getting started with introductions, we'd like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of the Zoom screen. Audio participants, please dial *6 mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot be speaking. I'm Jasmine Rosari, I'm from Neighborhood Partners.
And I'm so excited to see all these faces here and excited that we're going to mix things up a little bit and start with the case presentation. But let's just do our introductions first. And anybody who doesn't have their video on, if you can just turn it on at least enough for us to see your face and encourage you to keep it on. It really is a way for us to build our community, to be able to see each other and learn our faces and voices together. So I'm going to go down my list here and call out if you can just share your name and where you're from. That would be great. And we will start with Bill.
Hey, good morning, everyone. Bill Rowan, up here in Schuylkill County at the Counseling Center. Happy to be part of our meeting today.
So glad to have you, Bill, as always. Melissa.
Hi, everyone. Yeah, Melissa Taveras, Counseling Solutions of the Lehigh Valley, and soon newest member of the PACMAT.
Woo-hoo! Great to have you. My list is not cooperating with me very much. I keep switching around. Valerie.
Good morning. My name is Valerie Guerra, and I'm from the Community Behavioral Health Specialist for the Community Care Team, Population Health.
Wonderful to have you, Valerie.
Thank you.
Patricia.
Good morning. I'm Patricia Walters, also from the Community Care Team, Population Health.
Fabulous. Sophia.
Good morning, everybody. I am Sophia, and I am the second newest member of the PACMAT team, so very happy to be here.
Got seniority all of a sudden. Lori.
Hi, I'm Laurie Wagner, CCT Behavioral Health Specialist.
This is such a great turnout. Wonderful. Jillian.
Good morning, everyone. I'm Jillian Beecham, Lehigh Valley Health Network, Emergency Medicine and Toxicology, and one of the PACMAT team members and faculty.
One of my heroes. Frank Speranza. Woohoo!
Morning, all. I recognize a bunch of you. So family medicine physician, Southside Family Medicine.
We're so excited to have you here today, Frank. Kevin.
Hi, good morning, everyone. Kevin McNeil, Hamburg Family Medicine, part of the PACMAT team. Looking forward to this morning.
So great to have you. Layne?
Good morning, all. My name is Layne Turner. I'm the Drug and Alcohol Administrator with Lehigh County.
And a wonderful addition to our team here today. Thank you for coming, Layne. Mary? Mary on the move.
Yeah, Mary Stock-Keister, getting in my car to get to work. Practice lead for the Family Health Center, soon to be Valley Health Partners.
And soon to be doing some MAT. Really exciting. Paige. Let's see. Naomi, can you unmute Paige?
Got it.
You got it. There we go.
My name is Paige Roth. I am the Program Coordinator for Addiction Recovery Services in the Department of Emergency and Hospital Medicine, and I'm part of the PACMAC team.
Alexandra. And if we can see you for a second, that would be great.
Good morning. I'm Alexandra. I am one of the medical toxicology fellows, and I'm one of the ER physicians as well.
Great to have you. Rob Cannon, the ER in the house today. Hi, Rob.
Good morning, everybody. Rob Cannon, one of the emergency medicine physicians and medical toxicologists at Lehigh Valley.
Great to have you guys. Franklin.
Good morning, everyone. My name is Franklin Ortiz. I'm a behavioral health specialist working out of the 17th Street campus with the community practices, soon to be Valley Health Partners. Glad to be here with you guys today.
Wonderful to have you. Drew.
Good morning. I'm Drew Keister. I'm the Vice Chair for Education for Family Medicine at Lehigh Valley Health Network, and I practice at the Family Health Center. Excited to be here.
Brett, great to have you. Tommy.
Good morning, everyone. My name is Tommy Acevedo. I'm the Behavioral Health Specialist at the Family Health Center. I'm soon to be transitioning to Valley Health Partners. Very happy to be here with everyone this morning. Thank you for having me.
Wonderful having you here. Michelle.
Hi, good morning, everyone. My name is Michelle DePauli, and I am a behavioral health specialist with CCT Population Health.
Wonderful. Gina.
Good morning. It's Gina Hills, Program Coordinator for the Center of Excellence at Neighborhood Health.
Wonderful to hear you. And let's see. We have a 484 number. 484.
Hi, this is Heather Cromer. I'm the Behavioral Health Specialist with Bethlehem Township Hub with CCT Population Health.
Oh, great to have you, Heather. And we have a 610-213 number.
That is Gail Stern. Hi. I'm on my way to work, and good morning.
Wonderful. Terrific to have you. Introduce yourself, and we've got Naomi here.
Hi, I'm Naomi. I am integrated specialist here at Neighborhood Health Centers, as well as an echo specialist and a CRS.
Which is just a wonderful treat to have you here too. And I'm Abby Letcher, family physician here at Neighborhood Health Centers and for the Family Medicine and Lehigh Valley Health Network, and part of our PACMAT team. So we're really excited to be here. And we are going to jump right into a case. We've got a case hot off the press from our most excellent Frank. And because we are so hot off the press, I'm going to be filling in our case presentation form as we go. And for all of you out there who are considering, maybe I'll do a case next time, this is how easy it can be. So, Frank, do you want me to prompt you through questions, or do you want me to just kind of fill in as you speak?
Whatever works. I could kind of give a rundown on how it got started, and if I prompt.
Yeah. Do you have a question for the team?
Good morning. I have a coffee subscription.
Already. Give me 1 second to take your number.
Okay.
Okay. Any question for the group here, or more just kind of going through it?
Alrighty, can I have your phone number?
610.
I'm fine with just kind of going through and more just gratitude towards the team. Everybody's been great. I'm sure I may have missed something or something you guys could jump in. So if you do see something that would be beneficial for me, open to any criticism or help. So I could just kind of get started in how I'd come into this case. So just kind of like how I am today, sitting here in my t-shirt doing virtual care in the morning. And I had a patient that I had not seen for probably 4 or 5 years. She'd been seeing one of my partners in the practice present for a complaint of hand pain. So doing the virtual visit, kind of going through, started talking about her hand pain, and kind of out of the blue, she just said, I don't know why I want to tell you this, but I've been using heroin for the past 2.5 years and I really want to get off. And it was kind of a little bit shocking to me, but she felt really comfortable, and maybe it was, just kind of hanging out in a t-shirt and doing virtual care, and some of the connections you can still make virtually, which is really cool. And we talked a little bit more about it. I talked about all the options for her. She's still been working through all of this. Having been at the practice I'm at for about 7 years, and it being a practice that's been there for a while, I knew who her parents were, previous history of addiction. So she definitely had a high likelihood and a chance to be kind of caught up in this. She had a boyfriend had gotten her started, and once they had broken up, she had continued to use. One of the positives of COVID was she stopped being able to get heroin. So she was actively starting the withdrawal phase when she had talked to me. So she wanted to just kind of go into it. We talked about, further use of MAT, talked about resources for her. We'd reached out to Pyramid, who at the time was only working virtually. I'd reached out to Kevin, Abby, Jillian, and they did an excellent job kind of guiding me in resources for her. She had done an initial virtual visit with Clean Slate, but it was group therapy, and she was really scared to do group and have it be either someone she works with or someone she knows, logging into like a virtual atmosphere, not necessarily knowing who's there. So with work kind of going back into a busier phase, she had left that and sent me a message just saying, hey, I've been clean at this point for about 10 to 14 days. I'd really like to try either naltrexone or Vivitrol, but I really don't know where to go. I've been hitting some roadblocks. I'm scared about the group therapy. So Abby had set me up with Angela, who really helped walk me through a lot of what you guys do with PACMET. And it's just phenomenal. A lot of stuff that I didn't know we could even do in our FM offices. And even in my role, like as AMD, it's stuff that I was still surprised. I've been asking for Vivitrol for years, but never had an opportunity because Pyramid has just been so great and I've used it so much. I really hadn't pushed on it in the past 2 years or so. I'd heard Kevin and Jillian talk at our meetings, but never had the opportunity for myself. But this kind of really opened it up for me and let me have the opportunity to do this. So I brought her in last Friday. We did the naltrexone challenge in the office. She did fantastic with it. She felt really, really comfortable. She had been in the office since she was a baby. She had previously seen the physician there. She knew the staff. She was really comfortable with the staff. So it was a really, really cool thing. I felt really good at the end of it and just really happy to have the support from you guys. And this is more just me saying thank you and kind of telling you how well it went, because I was just surprised that I was able to do it so easily. And so happy for the patient. Now, again, I'm going to see her Friday. I've been following up with her just either via phone calls or via MileVHN, just checking in. Talked to her last night. She said she still feels really good. Still been going to work, has no real complaints. So yeah, I mean, again, still very hopeful things go well. I know this is not the typical that they do so well. I hope she does. I still have that nagging feeling in the back of my mind that we may need more support in the future. And I've told her that. I said, hey, this is not, if we do hit a bump in the road, it's not the end of the road. I'm here for you. We can do more help if we can. I've gotten some great help from the CCT team. You guys know I love you. I use you guys for everything and can't say how important you are to the work that I do, because I really can't do anything without you guys. So, okay, Abby, point me in what I missed.
You're muted, Abby.
I'm looking on my phone, so the screen's really tiny. So I may have missed something and I can't read it from this far.
No, I think you're good, Frank. They're unmuting on their end. I see. There they go.
Okay. Any other substances, Frank, other than the heroin?
Marijuana and cocaine. So she was feeling really tired with withdrawal and said, I'm going to try cocaine to see if it makes me feel better. She told me as soon as I saw her on Friday, she said, I felt awful. I never want to do that again. And marijuana, she said she's been taking to try to help her calm down, but really doesn't enjoy that. She'd actually stopped drinking 3 or 4 years ago. Bad experience with her family and said, I really never wants to touch alcohol.
Okay. One of the questions that we're often interested in is the adverse childhood experiences, and we're going to talk about that a little bit later today. Were there any other adverse childhood experiences? You mentioned the parents with addiction.
Nothing that had come out to me. I touched on that briefly when I did the PacMat Smart set. I know Karen probably had gone in a little bit further than I, but nothing that jumped out to me based on her history in the chart, and she's been patient at the practice for a while, so nothing she's revealed at least.
Okay. How old is she?
She is 30 or 31.
We'll call her 30. What would you say some of her strengths are?
I think the biggest one is her independence. So as a 30-year-old, she owns her own house. She's single. She said she, at this point hasn't depended on anyone. She feels really confident to be able to take care of herself. Very positive attitude. She's very open, both with me and the staff. So I think that's her biggest one. Just, how both independent and open she is, and open to change and getting better.
That's great. And you said she owns her own house.
Yep.
Do you know anything about her education level?
I do not, actually. I know she graduated high school because she graduated with one of the girls in my office's daughter. Beyond that, I don't know if she went to further education after that.
Okay. And do you know what she does for work?
She works at a local grocery store chain doing packaging and delivering.
Any legal involvement?
Nope.
Any medicines that she's on?
No. Well, birth control, but besides that, no.
Okay. And any other medical problems?
Nope.
Okay. So let's just go through real quick the DSM-5 criteria for the substance use disorder. And you probably can't read these on your phone, so I'll read them out for you, but it's useful. And I think they're in the smart set, right, Kevin?
No, they're not in the smart set. You have to bring it in currently.
Okay, all right. So our criteria for a substance use disorder are taking the substance in larger amounts or a longer period than intended.
I guess the fact that she's taking it at all, yes. So.
Right, like she kept using after her boyfriend left.
Yep.
Persistent desire or unsuccessful attempts to cut down or control.
This was the first time she had tried, but she did state that, she had the desire to keep using up to this point. So I'd say yes.
Okay. A lot of time spent in activities necessary to obtain the use or obtain or use or recover from the effects of the drugs. Ugh.
No, prior to this, she really had no issue getting it, she said.
Cravings?
Yes.
Yeah, and obtaining it, but also sometimes people talk about a lot of time, like it takes a lot of their time to deal with being high and recovering from that. So how about recurrent use resulting in failure to fulfill major obligations at work or school or home?
No.
Continuing to use in spite of persistent recurrent social or interpersonal problems that are high or exacerbated by the use?
At least not that she felt. This was, she said, life was easy with it. She just felt bad about it.
Okay. Important social, occupational, or recreational activities that she gave up or reduced because of the use?
She did say she hikes less, so I'd say yes. Just some of the things that she may have enjoyed because she was busy being high.
Yeah. Recurrent use in a situation which is physically hazardous?
At work, it probably, she might not realize her reaction speed is slowed and it's dangerous. I'd say yes.
Yeah. And sometimes I ask people about unprotected sex, or if they're having sex while they're high, that's pretty hazardous physically as well. Continuing to use in spite of knowing that that you have physical or psychological problems that are likely caused or worsened by the use.
I'd say yes.
Tolerance, using more?
No, she's been on the same amount since she had started.
I love my formatting, it's great. Withdrawal, yes.
Yes, yeah.
Right, so we count these up, right? 1, 2, 3, 4, 5, 6, 7. So what do we know, team, about how would you stage her use disorder? Let's have a little shout out from anybody. Mild, moderate, severe?
Severe.
How do we know that? 6 or more. Okay. Any lab work that you got? You mentioned that she had a UDS.
Yep, UDS, CBC, CMP, and pregnancy screen. And all the lab work looked good. UDS did show the cocaine, did not show the marijuana, but she admitted to both.
And no opiates.
No opiates, correct.
And I wonder if you wanted to comment, you were a little bit worried about that urine drug screen and what it might or might not show. Can you walk us through that timeline just a little bit of
So when I had first gotten it back, it had the preliminary positive for cocaine. You guys know how the H&L screens show, so it just kind of doesn't say that there's anything there. It hasn't positively tested yet. And my concern was, would she need more support than I could physically offer out of my office with, social distancing and the inability to directly connect with the counseling service? Would she need more than we can? But she openly admitted to it. She had talked about why she had done it. She said she really didn't see much benefit in it. So my big worry was that I couldn't do enough or wouldn't be enough for her. But Abby and I had talked about it, and she said, that's not a direct reason why not to proceed with what our game plan was, and making sure that the naltrexone challenge went well and that she was honest with everything else. So.
Great. Did she talk at all about any other behavioral health issues, diagnosis in the past?
She did not. And not having seen her for a while, I looked through the chart. I didn't see any previous history of treatment for anxiety, depression, any other psych diagnoses. There may be some, unmasked things she hadn't presented to the practice for, but she'd been roughly, about every 18 months or so, kind of what you'd expect at 20 to 30-year-old age. People don't come into the office too often.
Great. Let me open it out to the group, and I'll ask our PACMAT faculty group to hold back for a minute, and let's see what questions do we have from our participants. Clarifying questions at this point. And then for those of you who are new here, we start with a round of clarifying questions. What do we want to know more about for this case and about this young woman? And then we'll move on to some treatment suggestions. And Frank, I don't know if you have a question right now, but part of your biggest question was, am I enough, right? Can I do enough to help this person?
Yep.
Mm-hmm.
Hi, good morning. This is Vic Sandoval.
Oh, hey, Vic.
Yeah, I just want to clarify on the criteria on my checklist. Severe is 5 to 6, and the score was 7. Should that be a very severe, or we just stop at severe opioid use disorder?
6 and up is severe. So we just call it severe after that. And for a lot of our folks, we'll see people that come in that have all 11 criteria checked. But this one is still severe, even based on what we're hearing from Frank. And I think that's kind of notable, actually. But Vic, I'll send you the criteria with the staging. It sounds like you might have something that's a little confusing in your checklist. Thanks. Any more clarifying questions? Frank knows a lot about this young woman, so there's good stuff to discover, right?
I have a quick question. It's Paige.
Okay, Paige.
When she was going to clean slate, did you ask her, or did she tell you any more about how she felt being connected with, further outpatient treatment, or was she interested in any other services?
So she is. She would love to have a addiction counselor to help her with. So I know our CCT team is actually working with her. They gave her a series of phone numbers, contacts. So when I had spoke to her last Friday, she had just gotten the list and hadn't called anyone yet. And I did see something pop up in the chat. I'm gonna have to steal that later, but I didn't get a chance to copy it yet. When she had called Clean Slate, she actually had a really weird experience. She said they had done some of the intake, and the person doing her intake, when she told them that she owned her home, said, "Oh, you're a dangerous one. You're a bad girl." And she's like, I really felt really turned weird by that. So she said she actually ended the conversation at that point and didn't ever call them back. Pyramid, she had no issues with the intake, but the group is what kind of scared her there.
Thanks. That's really interesting information.
Frank, this is Layne Turner. Has your patient reported any history of domestic violence or domestic violence concerns with the ex-boyfriend?
She did not, no. And they'd been separated for she said about a year or so. So she'd been independently living and not having any contact with him, but still getting her substance in other ways.
And I'm the one who sent you the message for you to follow up with later.
Thank you. Yeah, I'll steal that once I finish on here. The phone's limited in Zoom land, and no wonder my kids have such a problem doing it for stuff.
Hey, Frank, this is Vic again. I got a question for you.
Yeah.
How did you make a decision whether you should use Suboxone versus Vivitrol on this case?
She made. She was very apprehensive of Suboxone. She was concerned that she'd be switching basically heroin for something else and wanted to move towards something she could do less frequently, less have to take something every day, less, I don't want to say less dependence on something, but she viewed Suboxone as something she'd still be taking and being dependent on.
Hi, this is Judy, nurse care manager at 17th Street. I just have a question regarding the time that she started to use. It sounded like it hasn't been terribly long, 2.5 years. Was there something that happened? Did she say anything, what happened at that time that she started using? And is her family supportive, her parents, and are they still using, do you know?
So both of her parents actually passed from substance use and abuse. Her brother is very supportive. Interesting enough, he's actually a DEA agent. So she said he's really mad at her. So it's just very interesting kind of scenario with that. She did not specify any reason why she started using besides that just being around that boyfriend at the time and he was using and it kind of led to her to do it. No specific. Her parents had passed probably more before I started there, so more than 7 years ago. But from opioid use.
I think we got time for 1 or 2 more clarifying questions. Let me ask our PACMAT team people for clarifying questions then.
Hi, Frank. How are you? This is Yamelisa Taveras.
Hey.
Question. I know you mentioned, she works, she's independent. Any other activities that she mentioned that she enjoys doing?
Exercise. So she said this is the COVID stuff, but hiking. Hiking was the big thing that she said that's something she is doing.
Perfect. Thank you.
I have a question. Frank, did you get the sense that she has any sense of kind of community belonging, like to, a religious or spiritual organization or any other kind of, I guess I'm looking for sort of non-family social support.
Not particularly. It mostly sounded like she's more by herself, doesn't have any pets or animals or, specific religious beliefs that she follows or partakes in. Mostly her brother, that's her person that she still talks to and confides in.
Got it. Okay.
Hi, Frank. This is Angie. So great case. It's so nice to hear cases like this where it seems like a good fit. So when you were talking to her, did she have any history of overdoses in the 2.5 years?
She did not, no.
And what about, was there any sense that you got, or based off what you know about her family as well, a history of behavioral health concerns or anything that you saw in your meetings with her that would have thrown up some red flags around depression, anxiety, or other behavioral health concerns that were left untreated?
Not really. I was looking for something like that when I had seen her in person, because some of that you do disconnect with the virtual. But no, nothing really jumped out. She was extremely, positive and very happy when I saw her, and just seemed in a really good place. And yeah, she could absolutely be faking it. But some of the stuff that when I see her again on Friday would be good to kind of follow up on and see how emotionally she's doing for all of this and kind of go from there.
Yeah. And that partner you mentioned that kind of got all of this going, where's he in her life right now?
I don't know, actually. She said she hasn't been with him for a year, but I don't know if he's, if he's a work person that he sees or how they still interact. So again, something else good for me to touch on.
Great. That's all for me. Thanks so much.
Hi, Frank, Sophia here. I was just curious as to what her routine is. Does she have a routine? You said that she is currently living at home. Does she have any other additional supports at home?
No, she's solo at home, especially with COVID. She said she really is not seeing many people. She still goes to work, so she gets up in the morning and goes to work. She used to go to the gym, doesn't do that anymore. So I know her routine's slightly off. She does have some friends, but again, not seeing them during this period of time. But I think just mostly kind of doing everybody's COVID routine now. Wake up, work virtually, or go to work and then return home.
All right, thank you.
Frank, I got a question about how you, just how you got this information. You know your patient very well, obviously. Is that something that, when it comes to considering how best you can help her, did you kind of go back for some specific information, or did you know a lot of this already just because, you're the type of family doctor you are?
Know a lot of it. I had actually seen her a few times previously, and probably an almost opioid issue. My partner had prescribed her a oxycodone for an ankle injury about 4 or 5 years ago. And she'd come back to see me and said, "Oh, I just need to refill on my oxycodone." I said, "No, absolutely not. You sprained your ankle. You shouldn't even be on oxycodone for this." And then she'd started following up with me afterwards. In the past 3 years, my availability in the office has been significantly less, so I hadn't seen her for her routine stuff. She saw my partner. She did her GYN care for her. But I'd known her for roughly 4.5, 5 years. So just a lot of stuff that kind of just in my head.
Thanks.
So I have a question for you, Frank. You mentioned that she was really anxious about Suboxone, which was sort of the lead choice when she first came into and was in withdrawal, and that makes a lot of sense. Do you have any idea where she gets her information about recovery and about treatment?
So she actually, one of the questions I asked her, where she had these thoughts about Suboxone, she said a lot of friends who previously used who have gotten clean over time. So she said she'd hung out with them prior to her ever start using, never had a desire to use when she was with them. It was the boyfriend that kind of triggered her. But she said she'd had a lot of friends that have done Suboxone, gotten clean, done other ways to get clean. So she knew a lot of the stuff that's out there initially when we first had our conversation.
Mm-hmm. We have the automatic lights going on in here. Sorry about that. Thank you. That's great. Let's think about some suggestions. What are things that come up that you out there in Zoom land think, oh, I would like to do this with this woman or something? Oh, wait, I have one more question. Sorry about that. Goal, did she state any of her own goals for treatment?
Besides stop using heroin, no. It's a good question and back from me. Is there specific goals we look for? Is there things, we try to prompt them to give us?
I'm going to turn that around to the group. So we can be thinking, some of the suggestions might be ways to think about eliciting goals from people, or what are some of the things that you've seen as helpful goals, and how do we get there? So let's turn it over to the group for some suggestions for Frank and his team. And I don't know if the behavioral health people that on your CCT, are they on the call, Frank?
Let me take a look. I've seen a couple who used to be with us behavioral healthly.
Mm-hmm. Anybody with names outside of Frank?
No, I don't think I see our current team. Anybody at Emmaus?
All right. But you've got lots of great help around here. So let's hear some suggestions from the group.
This is Judy at 17th Street. So just making sure that she has support. It doesn't sound like she, other than her brother who's angry at her right now, has much support. And you know, her goal is to stop using heroin, but also to have her come up with, you know, maybe another goal to also focus on, to just continue, and that she's able to work on to support, you know, her main goal to stop using.
Cool.
Yeah, this is Bill from up in Schuylkill. I mean, she sounds like she has some really good insight into what she wants to do and how she wants to do it. In my head, I'm already kind of coming up with like maybe this and maybe this for treatment, if indeed she engages in treatment. But really, I think like starting with her goal, I want to stay off heroin, presents the opportunity to say, let's talk more about that. Let's talk what might that look like? What do you think is going to be important for you? And off of that, to help her frame a recovery plan where we can just add services to it or add suggestions to it, because it does sound like she has some insight and some motivation right now. So starting with where she is and that just having that goal of I want to stay off heroin, I think is a really good starting point. And I also just want to say real quick that this is really awesome to see how this came together so quickly and how much support was available in the whole network for this in terms of being able to get her, triage that issue at the office visit, and then provide all this supportive work with it. This is incredibly awesome stuff.
Cool.
Yeah, I mean, really, the team is just phenomenal. Like a bunch of Tiger texts back and forth, and really emails, and everybody really did most of the other work. I just kind of showed up and guided her. So really awesome team, and thank you.
Awesome family doc.
So Frank, I'm not sure what the list of phone numbers is, you know, what that contains that you gave her, but I'd really like, you know, to see her connected, to have a conversation with a certified recovery specialist. We have a couple in the network now. One, Holly Maddox, works with me. She, you know, she would be able to speak with her on the phone. There's a bunch of really cool services, organizations. There's an organization I'm involved with called Sync Recovery. And we do events for people, like we do a couple hikes, you know, organized hikes where we'll meet somewhere, we'll hike 6 feet apart, and then kind of end with not really a 12-step meeting, but a recovery meeting, and maybe do some yoga, mindfulness. So, you know, it would be great for her to, she could go online and look that up and read about that, or, you know, give her my name, because, you know, I'm involved with that organization, and, you know, to find some like-minded people who are in recovery, I think is really important. We need to find our tribe. You know, and she sounds like she's got it together pretty well. And I think that's key.
No, that's awesome. Thank you. Can you drop me an email just with some of those numbers and stuff?
Absolutely.
I want to say thank you to all of you, but I also, I have some virtual care to actually do at 7:40. I have a patient that sadly was diagnosed with more metastatic cancer last night. I get to make a phone call this morning and talk about hospice. So I'm going to hop over to that one. Probably got to take the Sixers shirt off and put something nicer on for that call. So quick. And
thank you, Frank.
Okay. Thank you all, and have a great day. And thank you for all that you're doing.
Frank, we're going to keep gathering some suggestions, and we can send those to you. And if you want any further conversation, look at the tribe you've got. These are beautiful people.
Pretty awesome. Yep. Thank you. Have a good one.
Great work, Frank.
Bye-bye.
All right, team. What else do we think of for this patient?
We actually had a suggestion come through chat that's similar to Paige's suggestion. So Layne stated that she can call Mars and he provided the number, which we'll provide to everyone as well. And she can ask for a CRS. So along the same lines that Paige. And they offer one-on-one video support chat. And it's a free service. Thank you, Layne.
And I think Mars also as the outpatient provider would be ideal. I think their approach is a lot less intimidating than many others. So if that was part of the resistance, so not, you know, I think linking her with CRS through the network would be a better option for her just because she has been attending for so long. And then Mars kind of working hand in hand. And I know that they do work with Sync Recovery as well. So I think that's a great suggestion.
Can you remind me what counties Mars serves?
Lehigh, Northampton.
Thanks.
Great suggestions. What else we got? I think one of the things that was interesting in this case, and I asked Jillian to speak about it a little bit, and I'd like to hear from the rest of the group too. The trajectory that we had was first a patient came in and was in withdrawal and asking for help, and was referred to have an evaluation and be an induction for the Suboxone, and that didn't work out for this patient. And what we then heard was, well, I think that I'm going to try and stay abstinent long enough so that I can get on the Vivitrol. So that was sort of stage 2 with some uncertainty in it about whether that was going to work. And then stage 3, she came in for her urine drug screen, and the preliminary was no opiates, but still not quite clear cut. And then stage 4, she came in and actually did okay with an naltrexone challenge. Wonder if anybody has some thoughts or suggestions about moving through those different stages. That was part of what was challenging for Frank and challenging for the patient too, of that kind of uncertainty in 2 weeks. How do you navigate through that with somebody?
I can start. So I think it can be a potentially very tenuous time. And I think to start, I noticed that a lot of patients will start with that conversation. And sometimes I think they're sort of testing the water to say, I don't think I want to do Suboxone because I think it's just, swapping one substance for another. Sometimes I think people are looking to see what the response is going to be to that, because many times I'll explain that we really don't see it that way. We see it as a medication to support recovery, which other substances like heroin or fentanyl are not intended to support recovery. In fact, they place you in a cycle of using to get higher to feel normal, and then withdrawing, needing to find another dose. And it's a constant cycle where something like Suboxone really stabilizes the brain to allow you to engage in the recovery process, get back to who you really are, rekindle relationships, feel a little better at work, put all those pieces back together. And oftentimes I find once I mention that to people, they're very quick to say, all right, that would work for me. So I don't find it's much of a battle. And I think people just need to hear that very brief explanation. Now, if in this case, it sounds like this is a pretty independent person. She sounds like she has a lot of strengths, and she may have truly made that decision that Vivitrol would be best for her. And she's seen other people with on Suboxone, and so maybe she feels strongly about this. What I would tell her is a couple things. One is that because although it plugs into the same place as opioids, because it's a blocker, she doesn't quite have the support she needs necessarily in the brain to get through that tenuous time when you're first engaging in abstinence. There may be cravings. Sometimes, Vivitrol can help with cravings, but initially that support that Suboxone can provide wouldn't be there. So I would ask her to help identify kind of people, places, things that might trigger her to have a recurrence of use and what she might do if any of those things come up. And I might also talk about post-acute withdrawal syndrome, where people struggle with anxiety, feeling overwhelmed, sometimes insomnia issues, and that can happen over the first weeks and months of cessation of opioid use. Whether you're on Suboxone or Vivitrol, those symptoms can kind of come through. And so no matter what her decision would be, I would ask that she recognize when that's happening. And again, same thing, be able to name those potential feelings and to have a plan. Sometimes what we'll end up doing is prescribing some medications to help with that. So even if she chooses Vivitrol, clonidine, hydroxyzine, some NSAIDs, things like that, to help her through some of those, post-acute withdrawal symptoms, particularly clonidine and hydroxyzine as needed, I think might be really helpful to support her during that time. So I think really just shared decision-making with an awareness that time period, kind of weeks and months around her decision to enter that recovery trajectory, is a tenuous time that's going to require a lot of mindfulness on her part, and potentially the support of some adjunctive medications, particularly if she goes with Vivitrol over Suboxone.
Thanks, Jillian. Do you have a nice little summary that you can include at some point for the pause and how to manage the post-acute withdrawal syndrome?
Oh, sure. Yeah, we could put that together.
Cool. All right. Any other suggestions?
Abby, one of the things that you asked, this is Drew, you talked about like that difficult time when more's coming out, things are uncertain. You find that you haven't heard everything from your patient on the initial encounter. Obviously, super common, especially in a case like this where somebody's like, he even said, like, she said, I'm not sure why I'm telling you this, but, so she didn't necessarily have a plan to come to him and ask for help. There she is. And so, I don't know. I mean, I think one of the things that I think has been a real challenge from the perspective of the medical system in the past, and certainly the system in which I trained, was we tend to, when we find that person has used cocaine and they didn't disclose that to us, we tend to move into sort of a gotcha mode, that kind of thing. And it kind of, I think that can really sour the relationship, and it can really, from both sides, right? So the clinician can begin to doubt their trust for the patient can feel very judged by that. And so I think in this case, it sounds like with the help of the team, Frank did really well in terms of kind of reaching out to her, clarifying what happened there, and meeting her where she was, which is, I think, something that we don't always do really well. It wasn't a part of the way, like I said, the way that I was trained. And so it's something that I constantly have to remind myself when I'm faced with a situation like this.
Mm-hmm. Mm-hmm. So I think what I'm hearing you say is that, keeping this focused on building the relationship and monitoring our own emotional reactions when we're faced with someone that's in some real distress about this, and our usual habits that we learn in medicine about how to interpret some of these tests, and maybe that also are part of the treatment world of, you got to be off of everything, and projecting some stigma that we have options for doing that differently with the interpretation of urine drug screens, or talking to people about their condition and what recovery might look like, and that Frank has modeled how important that relationship is to help kind of guide those decisions. And I think it was an interesting moment when he was texting of, oh, there's the cocaine in there. Does that mean this is kind of out of my league? And the beauty of a family primary care approach is to say, well, you know, a piece of this may turn out to be pretty complicated, but there's nothing about that that says that this person can't get treatment for their opioid use disorder right now. And that just took a little support to be able to remind ourselves that this was an approach that might work well for her. So he was able to stay open in a beautiful way to see her virtually and help make a decision that would be good for her. So that was kind of cool. And it goes dark again. One more suggestion from our team.
This is Angie. I think, Drew, I'm so happy you brought that up because, you know, when I hear this case, it's almost like I want to say, you know, don't be surprised if along the way other substances pop up. In fact, think of it, shift it in your head as an opportunity to learn about her recovery process for you as the provider and the behaviorist, and for the patient, for the first time for somebody to say, hey, when you're ready, let's look at what showed up in your urine drug screen and talk about your recovery journey, your recovery continuum. And it sounds like she said, you know, I was really tired and I was trying to figure out how to get through that period of just feeling like, you know, a slug, and cocaine was looking really good. So then now we can go back and say, you know, what other tools can we put in place as your physician, as the behavioral health team that's surrounding you? And those really become opportunities to push the person towards their continuum of recovery, of health, wellness, and purpose. And so if we can not come from it as a gotcha standpoint of, let's talk about this when you're ready to have an open conversation about it. The other thing, like, that are just like gentle reminders that patients often forget about, like with Vivitrol, we often see this with other medications we use for use disorders like antabuse, that patients can use on top of it and try to push through the Vivitrol. And one of the risks of overdose with Vivitrol is that in the midst of a relapse, the patient will try to take a lot of opiates to push through the blocking effect of opioids. So talking to your patients about, you know, the risks of overdose that will put them in, and what are some harm reduction strategies and techniques and ways to manage those cravings if they should present. And then this is just a gentle, loving reminder for everyone on the call that when we talk about urine drug screens, we talk about people being negative or positive in their urine drug screens, and just trying to avoid words such as clean or dirty. And it is, we as a profession and a field, even in the addictions field, use that language for a long time. So recognizing it and replacing it. And we can also talk about somebody moving towards their recovery as substances come down or come out of their urine drug screens. And then lastly, is I want to remind everyone, so there was a complete level of care assessment done with the team. And so over time, one of the dimensions on the level of care assessment is the emotional and behavioral health dimension. And so, you know, how she scored on that behavioral health dimension, we can connect her with behavioral health services. But really taking into consideration, like, not what we think is going on in her life, but what she's telling us, and collaborating with her on those items, and moving her over time towards her recovery. And that's all.
Thank you.
That's great, Angie. I just want to piggyback on that, putting myself in the patient's shoes, having a conversation with a physician, kind of in a scenario that Drew was laying out there. You know, I would be extremely appreciative if the physician said to me, you know, as a way to broach, you know, there were other things that showed up in your screen, you know, for them to just emphasize that, you know, I'm here, I want to be your partner in this. And, you know, whatever's going on, I want you to know that I'm not here to judge you, but I really, you know, would like to help you through this. And that's really, you know, I think just saying that and you know, gaining somebody's confidence can totally change the dialogue, can totally change, you know, the relationship. And I, you know, because we see patients in the emergency department all the time who come back with screens with all kinds of things that they're not, you know, they're not telling us about. And sometimes it's important to say, you know what, I'm not judging you, trust me, but you know, what's going on with this? Can you tell me? Because I'm just here to help you. Yeah, that makes a huge difference. That's all.
I just want to add, this is amazing. This is beautiful. I think over the past 2-3 years working alongside as an outsider, but alongside with LVHN and seeing the approach of integrating substance use and non-stigmatizing language, educating the physicians, family practitioners. This is a case that would have probably fallen right through the cracks 2-3 years ago that we would have totally missed. And this is just beautiful. So thank you.
Yeah, just a comment also on Dr. Jillian's point about post-acute withdrawal. We've seen a lot of patients that, again, when they're in that early recovery phase, they've got these emotions that are kind of coming through for the first time, and they're just trying to find their way. And they really do get sometimes very concerned, if you will, like, what's going on? Why am I feeling the way I'm feeling? And just a lot of really anxiety for that. And really having that conversation and really spending time talking about post-acute withdrawal and normalizing it for them and helping them just understand what PAW is and how to manage that can just really be reassuring for them. And just, I think, just a really important conversation that validates for them how they're feeling and why they might be feeling that way. Because I've just seen a lot of them say, oh my gosh, I'm just not, like, something's going on and I'm not okay with it. And they begin to kind of question, what journey am I on and should I be on it? But that reassurance in terms of, hey, this is what PAW is, this is what it looks like, and here's how we manage it, I just think can be very, very important in the early part of recovery.
Thanks, Bill. That's great to hear.
Abby, I'm sorry, I just have two more things to say. The first is that, you know, Frank did a tremendous job, and I think it was openness and courage, and it's just a great family doc. And I think that the reason why it was successful is because, as Frank said, the support that he was able, that everyone here was able to provide for him. And I think that's important as we think about how we extend this with other family docs and primary care physicians. That kind of support is really what's going to what's going to determine success and get people the care that they need. The second thing I wanted to say is, Frank had mentioned about a previous encounter with the same patient and just how we need to continue to do a better job when it comes to evaluating pain. And certainly we're doing a better job of not prescribing opioids when it's not indicated, but always to keep in mind, like, that's that pain visit opportunity to see if patients have other problems like undisclosed or undiagnosed substance use disorder. Something we need to continue to work on.
Thank you, Kevin. I think that's a really important piece for us in the family medicine world, and I think also for the emergency department folks, of how do we dig under that layer that we've been trying to work on understanding that we've been prescribing too many opioids. But the flip side of that, of just focusing on ourselves and our own anxiety and feelings about that and saying, no, I'm not going to prescribe any opioids, that's not an adequate response, that we need to go that next level and figure out what can we do to help this person, because if they're asking for this medicine, they clearly need some help and we probably haven't identified exactly what it is yet. So super helpful. What a great case. Thank you all in our community here for jumping in and helping us think about it and see all the richness. And I really want to extend a huge thank you to Frank, even though he's not here, but he's heard me gush about it a little bit before, for the willingness to to be responsive to the patient in the practice. And Frank has been saying, I'm going to start doing this maybe in August, right? But then the case presented itself before he was ready, and he was able to reach out to the team and do it. So I'm also really grateful that when he reached out to the team and things had worked out on Friday, and he was feeling really positive about how it went, when I said, will you present that on at the Echo this week? He said yes, and even though he didn't get the form in time to be able to fill it out, he still presented the case. So just really grateful to his willingness to jump into the unknown and take a chance. And it looks like that's really what our community needs us to do as family docs. And really great that we have support of whole integrated teams to make that jump worth it. So we're going to transition. There are a couple of people that joined the call that I'd like to have say hello. So Terry, can you unmute yourself for just a second and say hello and tell us where you're from? We'll come back to Terry, but maybe in a linked way I can say, Vic, are you still there? So Vic Sandoval and Terry are both from the Trexlertown practice. Lynn, are you there? You want to say hi? Yeah.
Yeah.
There's Lynn. Hi, Lynn.
Hello.
You can just tell us who you are and where you're from, and we welcome you to our Echo.
I am Lynn. I am a geriatrician and family medicine physician with Lehigh Valley Health Network. I work at the 17th and CHU office, seeing patients there.
Wonderful, Lynn. Thanks for joining us. Terry, we're going to try and unmute you and see if that helps. Terry Norcott. We can't unmute you either. Oh, there you are. You're unmuted. Okay, let's try Stacy. Stacy Cook. Stacy, we're having trouble unmuting people too. I don't know whether that's, oh, mic not working from Trexlertown Family Medicine for Terry. Great. And let's see. Judy, I think you introduced yourself, Judith Enrique, right?
I came on a little bit late to introduce myself, but I'm Judy. I'm the nurse care manager at 17th Street of the community practices. I was part of ECHO last year and really enjoyed it, and really glad to be back again this year. It's really great, the things that you know, you learn and see from the meeting. So really glad to be here.
Great, wonderful to have you. Jessica.
I'm Jessica Morris, one of the behavioral health folks with CCT.
Thank you, Jessica. Great to have you here. Christopher Nine.
Good morning. I'm Christopher. I'm a behavioral health clinical coordinator with the community care team at Muhlenberg Hub.
Oh, wonderful. Yunji.
Morning. I'm Yunji. I'm one of the family medicine residents at the Family Health Center.
Wonderful to have you here. The 610-402 number.
Stacy Cook, I believe.
Oh, is that Stacy?
Hi, yes. I'm sorry. I attempted to unmute myself before, but I think you had me muted on your end. So I'm Stacy Cook. I'm the manager of behavioral health integration and consultation liaison through the Department of Psychiatry.
Great, wonderful. And Heather we have, and I think that's everything. Did I miss anybody? Fabulous group. Really glad to have everyone here. Okay, so we're going to transition over to our didactic session with Dr. Angela Callistra. We'll be talking about ACEs. Go.
Thanks so much. Can everyone see my PowerPoint slide or the PowerPoints? Great. We're going to try to move through this efficiently so we have time for another off-the-cuff case before we wrap. So for all of you out there thinking that maybe you're thinking of a patient and you want some recommendations, we're going to hopefully leave some time for that. So if that's speaking to you, begin thinking about your case. So we're going to talk about adverse childhood experiences, or the ACEs, and addiction. So how adverse childhood experiences can help us all understand people with substance use disorders. I'm Angela Callistra. I'm Director of Behavioral Sciences and Family Medicine, and I oversee addictions and behavioral integration for the PACMAT. So it's a pleasure to be talking on this topic, and our caseworker, Sophia Harbove, is going to join me for a few slides as well. I don't have anything to disclose. So at the end of the presentation, you're going to be able to talk about what the ACE study was, how our adverse childhood experiences related to later substance use, and how does understanding the link between the ACEs and substance use disorder inform our treatment decisions and our engagement. So my hope is that most of us have received some education on the ACE study. So I'm going to move fairly quickly through these parts of it and spend a little bit more deeper amount of time when we think about the connection between ACE and substance use disorder. So the study was prompted by some observations in the mid-1980s at Kaiser Permanente's Department of Preventive Medicine. And they were looking at patients who successfully lost weight in the weight program, and they were the ones most likely to drop out. And they asked themselves, is a personal solution the cause of a public health problem? So the study itself examined the relationship between the exposure to 10 different ACEs, adverse childhood experiences, we'll look at those specifically, and physical and mental health status as an adult. So how does what happened in childhood impact the physical and mental health status as an adult later in life? And the study just found a direct dose dependent. So what they mean by dose dependent is the amount of adverse childhood experiences. So a direct dose dependent relationship between the number of ACE, or what they call an ACE score, and negative physical and mental health outcomes. And they could come to a number of how many ACE would lead to, how many of the ACEs, how much of a dose of those would somebody need to make it significant for them later in life to have significant physical and mental health outcomes, negative outcomes. So if you haven't taken the ACE yourself, I think that's really important as well, or engaged with the patient around the ACE. This is what the ACE questionnaire looks like. It's quick, it's 10 questions, and we'll look at specifically what they're measuring, but if you just take a quick glance at it, did a parent or other adult in the household often swear at you, insult you, put you down, humiliate you, and it goes on. Did a parent or other adult in the household push, grab, slap, or throw you, hit you hard with something, leave marks, touch or fondle you? Did you often feel that no one in your family loved or thought you were important or special? Your family didn't look out for each other, feel close to each other? Did you often feel that you didn't have enough to eat, had to wear dirty clothes, had no one to protect you, or that your parents were too drunk or high to take care of you? Were your parents ever separated or divorced? Was your mother or stepmother often pushed, grabbed, slapped, or something thrown at her? There's some more questions underneath that one. Did you ever live with anyone who was a problem drinker or alcoholic or used street drugs? Was anyone depressed or mentally ill in the household, attempt suicide? And did a household member go to prison? And so you add up all of the yeses or ones, if you will, and that's what gives somebody an ACE score. And so what the study, and I want to say the initial study that happened from 1995 to 1997 happened in 2 waves, and they collected data from 17,000 individuals. And there were some limitations with the study findings as well. Sophia will talk a little bit about those. But the ACE study, essentially, they had lasting effects on health, obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, COPD, broken bones, behavior such as smoking, alcoholism, and drug use, and just somebody's life potential as far as graduation rates, academic achievement, and loss of time from work. And the significance in the number count came after somebody had 4 or more of the ACEs, adverse childhood experiences. And I just wanted to pass it over to Sophia, see if I missed anything. I know you wanted to make a few remarks here early on.
Oh no, that's fine, thank you. I mean, basically what that means is that the higher the ACE score, the worse the health outcome would be. So patients that experience like 4 or more categories of childhood exposure compared to those who had experienced none had 4 to 12-fold experienced health risk for alcoholism, drug abuse, depression, and suicide attempts, and a 2 to 4-fold increase in smoking, poor self-rated health, greater than 50 sexual intercourse partners, and sexually transmitted diseases. So there is a pretty significant jump from somebody that had no ACE score to somebody that had even a 1 or 4 ACE score.
Thanks, Sophia. So which ACEs were included in the study? And we looked at that questionnaire, but just to break these up into categories, they had 3 forms of abuse that they were asking questions about: sexual, emotional, and physical, and 2 forms of neglect, emotional and physical neglect. And they also had 5 forms of family challenges, which are listed here: battered mother, parental separation or divorce, mental illness in the household, household substance abuse, and incarcerated household members. They collected data along 2 waves. Wave 1 happened in 1 year, and then wave 2 happened in the next year. And wave 2 involved a more thorough analysis of the link between ACEs and addiction. Did I miss anything on these slides, Sophia, about the study?
Well, I think it's interesting to note that the subject pool was 70% Caucasian and 70% college educated as well.
Yeah, that is super important, because sometimes you give the questionnaire, and I've had this experience. So I give the questionnaire to somebody and they laugh at it. That the questions don't nearly capture what their adverse childhood experience was. I've had somebody look at me and say, does it count if your father regularly held a gun to your mother's head, or hearing shootings outside? I don't see anything about shootings, regular shootings. And so sometimes the ACE questionnaire seems not as significant to some. And, you know, so there's all sorts of reactions when we think about who these waves were normed on and not. Good point. So when we think about the prevalence of these types of ACEs they were looking at in these 17,000 individuals in wave 1 and wave 2, this was the percentage of people that reported abuse, emotional, physical, and sexual, household challenges as listed below, and then emotional and physical neglect for the people that took part in this study. So 1 in 8 people out of the 17,000 had 4 or more ACEs. And that's the yellow in the chart here. So 1 in 8 people, it's pretty significant. And so when we think about that, when they think about mechanisms by which adverse childhood experience influence health and well-being throughout the lifespan. So essentially you're looking at in the childhood time span, these experiences happening. As a result, those experiences begin to disrupt neurodevelopment. And we ask questions about that in our evaluations and our assessments. So for all the behavioral health specialists on the call, think about the questions we ask, like, anything happen in your development as a childhood? Were you on an IEP, or did you have trouble learning or progressing in school? These are all really important indicators of some other things that maybe were happening. From there, you see impacts on social, emotional, and cognitive impairment. We'll look at the age range when they begin to adopt health risk behaviors, the adoptions of these behaviors, which might include substance use disorders or high risk use behaviors in adolescence, and then disease, disability, and social problems, which ultimately begins to lead to early death. So when we think about the adverse childhood experiences and substance use disorders, the data based on wave 2 of the study, these were the descriptives for that. We had 54% women and 46% men. Mean age was 55 years old for women and 57 for men. 73% of women and 75% of men were white, which Sophia is mentioning here. 32% of women and 42% of men were college graduates, 8% of women, 7% of men had not graduated from high school. And so in wave 2, they really were looking at somebody, later in life, and then having them look back and see how those adverse childhood experiences impacted them across the span of their development. So some of the key concepts here is that they're describing, and I'm going to talk about these here in future slides. Lifetime use equaled the question, have you ever used street drugs? When they're looking at drug problems, have you ever had a problem with street drugs? Addiction, have you ever considered yourself addicted to street drugs? And parental use, have you ever injected street drugs? So for these questions, the mean age of initiation was just under 20 years old of when they answered yes to these questions: lifetime use, drug problem, addicted, and then it goes through early adolescence, mid-adolescence, and adulthood as 19 and older. So what we know is that the ACEs and substance use disorders, the ACE travels in clusters. So if exposed to one ACE, the median probability of exposure to a second ACE was 86, nearly 87%. And then the median probability of exposure to 2 additional ACEs was about 70%. And so once we start seeing 1 or 2, then their probability for ACE and substance use disorders begins to go up. Each of the 10 ACEs increased. Sophia was mentioning this too on some of the previous slides around just the impact around health disparities over the lifetime. We also saw this increase happen with ACEs and substance use disorders. There's a 2 to 4 times likelihood of early drug initiation with each of the 10 ACEs as they increased. And then the likelihood of drug initiation during mid-adolescence and adulthood, and also a 2 to 4 times likelihood of lifetime use. So with every increase of one of the ACEs, we began to see this likelihood of drug initiation and lifetime use begin to increase as well. So a higher ACE score reflected essentially an increased risk of initiation, illicit drug use during early adolescence. So the higher you know, the ACE, we can begin to make some hypotheses here that can be tested, that there's a likelihood that they started using drugs, alcohol, or substances in early adolescence, mid-adolescence, and adulthood in a strong and graded manner. So over time, you begin to see it move from recreation or experiential use to high-risk use into some mild, moderate, and severe use disorders. Initiation during early adolescence had the strongest graded relationships with the ACE score. And then there was a statistically significant for ACE scores of 2 and above. So for every increase of the number of ACEs, the likelihood of initiation of illicit drug use increases, as we see below, 40% during early adolescence, 10% during mid-adolescence, 10% during adulthood, and 30% at any age or lifetime. Now, this isn't surprising, right? So if we think about the ACE score increasing likelihood in a dose response manner of, you know, trying drugs, getting addicted to drugs, and some sort of, you know, drug use seen in their parents. So as the ACE score increased, there was a 30% to 40% increase in risk for each of the 3 illicit drug problems that we would see. So if you're exposed to at least one ACE, you're going to develop each of the following problems due to that exposure. And there was, they called this an attributable risk factor. So as 56% for every, if you're exposed to just one, 56% ever having a drug problem, 63% addicted to illicit drugs, and then 64% some sort of parental use later in life. And so what does this do for us as providers when we think about these ACE scores? Like when we think about, well, how does this transform the information we receive from a patient when we get that ACE score, and what we need to recognize as we begin to engage and collaborate with the patient as they move through the recovery continuum, and as they begin to open up and as that relationship continues to solidify. So we need to remember that the unrecognized ACEs are likely the major determinant of what kind of contributes to somebody becoming addicted to psychoactive substances. And over time, somebody may be unconsciously seeking some sort of relief from the trauma. So, you know, often it's not uncommon for providers to treat the opiate use disorder and for the medication to work, for Suboxone, for Vivitrol to do what it's supposed to do, treat the brain and keep the individual from using opiates. But then we may see over time them pick up another substance that they haven't used, that they weren't interested in, because they're still trying to manage the presence of the trauma and the flooding of those experiences or the triggers that they haven't began to unpack with a professional or a recovery specialist or some sort of support group. We also know that because these ACEs travel in clusters, there is a complex failure of family and community systems. So all of this isn't the patient's fault. So when you think about what happened to them, what they were the recipient of as a child, you begin to understand some of the trauma and triggers that they continue to experience in their adult years. You know, we can take any system of oppression, poverty, war, racism, gender inequality, domestic abuse, and predispose that to these adverse effects, right? And so, you know, poverty is trauma. Poverty is neglect. Neglect is trauma. You know, when somebody can't afford to feed their children, provide adequate care and comfort, those are questions of trauma, right? So some of these clusters reveal not only family problems, but community systems and society failures as well. So hopefully what this begins to do is allows us to soften how we see the patient sitting in front of us, the experiences that they have endured, their resilience, and also their ability to get well. It allows for deep understanding of what's to come in their narrative as we build their relationship, to begin to practice our use of motivational interviewing, which allows us to pull up a chair next to these narratives and also understand, while over time we might see, you know, somebody is getting treatment for their opiate use disorder and now they're using cocaine, and that there's more to the narrative that we're going to express empathy for, provide person-centered care for, and that we have hope in their ability to get well. And so it really does lay the foundation for trauma-informed programs, organizations, and systems, and that we realize that just in this study of 17,000 people, of the percentage of people that had one or more ACE, and we understand that these ACEs travel in clusters, and we understand with each cluster we see a 2 to 4 times likelihood that they began to use substances in adolescence. And if they began to use substances in adolescence, their likelihood for continuation of use throughout their adulthood years then becomes even more increased, right? And that trauma, that for some of our patients, they haven't even named it that. They haven't identified it as that, but it's there and it's being triggered, and often we see those triggers, right? And so we realize the widespread impact of trauma and understand the potential paths for recovery, recognize the signs and symptoms of trauma and patients, family, staff, stakeholders. And I really encourage everyone, like these, just to take the ACE, because it's not just our patients, that these are experiences that humans, we're all humans, and that people go through. That will respond by fully integrating knowledge about trauma into policies, procedures, and practices. And there's all sorts of lectures and understanding about building trauma-informed systems, and we seek to actively resist re-traumatization. Some of the basic interventions that we can recognize as providers is that survivors of these experiences often welcome being respected, informed about decisions that are being made about their care, connected to trust is really important. They're often making decisions about those connections and trusts really quickly into meeting somebody, and language that's being used, and hopeful regarding their own recovery. There's an interrelationship between trauma and symptoms of trauma, which we just talked about, but in addition to substance use disorders, there's an interrelationship with eating disorders, depression, and anxiety, and how people are managing and holding that trauma in their lifespan, and a real need to work in collaborative ways with survivors, family and friends of survivors, other human service agencies to empower survivors and patients. We have some great evidence-based treatment that aims to treat trauma and substance use disorders, and one of those is called Seeking Safety. Seeking Safety. It's a manualized, highly flexible, evidence-based treatment. It was developed in 1992. It treats both trauma and addictions. It can be done in individual or group therapy. It can be done by any level of provider. There's no specific need for training for this unless you're going to be conducting research on the outcomes. That's the only time you need to go and get training. What's wonderful about this is it's manualized. There's 25 sections about how to address trauma and addiction in care. and you can implement it across many different platforms, and it gives you a summary and orientation of what you would discuss in the session if you were going to discuss one of these topics. And so if you think about a patient that's had one of these, that's had a cluster of ACEs, often what we find is that they're recreating unsafe relationships, that they often frequent and are attracted to environments that feel normal to them but are triggering and traumatizing to them. And there's all sorts of unsafe situations in communities and in relationships that they haven't figured out how to navigate through or out of, right? And so the manual helps them walk through what is safety, what is PTSD, how do you begin to take your power back from being triggered and flooded, and the grounding techniques that are needed to detach from the emotional pain, as opposed to always having a aroused parasympathetic nervous system and always being on edge or feel like somebody is out to get them, right? And so there's a lot of grounding work. And it walks you through just 25 different things that patients can work on. And the best thing is you can just give these practical issues and these strategies to your patient and just talk about them for a couple minutes in a session. So they're very doable. The manual does all the work for you, and it's very affordable as well. So it helps them attain safe relationships, thinking, behaviors, emotions. It's integrated into treatment to both treat trauma and substance abuse at the same time, focusing on ideals and effort to counteract the loss of ideals in both trauma and substance abuse. It has 4 content areas, and there's attention to the clinician processes, including emotional responses and self-care. If anybody would like more information on seeking safety, we would be happy to provide that for you and talk a little bit about how it can be integrated into your care if you find that you're seeing more and more patients that this fits the intervention strategy. So that's kind of wraps up the end of this presentation. Hopefully you're able to talk about what the ACE study is, how ACEs relate to later substance use, and the understanding of the link between ACEs and substance use disorder informed treatment. Any questions? Fantastic. I think that leaves us just enough time for a off-the-cuff case.
Yeah. Thank you, Angie. That's wonderful. And I think, we can both think about, how does the information that was presented in this about the ACEs and the trauma-informed response or the seeking safety, think about that for the case that we already heard, for some of your own cases that might be rattling in your head. And we do have time to do another case. So if somebody is, there's been something percolating, or often the way I think about these things is somebody's face pops into my head and I think about that person to try and understand the information. Whether this is somebody that you have in treatment right now or not, we can do an off-the-cuff case. They are often the most fun because it's something that is on your mind right now. And these, a case, I would invite anybody who's on this call, whether you're prescribing or doing counseling, whatever your role in the team might be, care coordinating, we would love to hear from your point of view. What's the case that's on your mind? Maybe related to ACEs, how it plays out. Maybe related to how do our teams work together. gonna stop.
This is Kevin. I have a question that I'd like the group to help me with. So, so I have a patient who's in her late 20s, and she is on Vivitrol treatment for heroin use disorder, and she started that in a treatment program, but prior to that was incarcerated for, well, she was incarcerated, and she's been in treatment here for several months. I took over the Vivitrol treatment, and she's been doing well, but a lot of increased stresses recently. Certainly COVID-19 related, but also work stresses. It's hard. I think that the work, it's work is challenging when you have had a history of a substance use disorder, and I think she describes in a way that she's not treated fairly. Has to work long hours, et cetera, and also a lot of family responsibilities now. She has good family support, but her brothers, they have been essential workers, throughout this, and throughout the pandemic, and their kids don't have childcare, so she's been taking care of her nieces and nephews in addition to her work. So a lot of stress is coming up. I texted to Jillian and Abby last week because it was longer than that. It was about 2 weeks ago or a little less than that, because she had been sort of not, she had been trying to switch her appointment or not coming into her appointment for Vivitrol. We were trying to reach out to her and work around her schedule, which we were able to do, and that was good. And she did come in and get her Vivitrol treatment in the time that she needed. But the urine drug screen was inconsistent, showed some alcohol, which was something that she hadn't, a substance that she at least hadn't, when we talked about it previously, had problems with before. So been having a tough time getting in touch with her. I actually finally did just now, actually, because this was a time that I could speak to her. And so we spoke a little bit. I think that she'd really benefit from a CRS, which she's open to. But I've been having trouble connecting patients here in my practice in Hamburg to CRS. So that's the situation. So any input about how I should proceed, it would be appreciated, and especially if I could get her connected to a CRS, that would be wonderful.
Right, and part of the trick for the CRS, and you mentioned at your practice, is that you're in Berks County, and all of these resources are county specific frequently, right?
Yes.
Okay, great. So I hear the question there is a patient who's been coming to you post-incarceration, getting her Vivitrol injection, but you're concerned because you're seeing some evidence of use of alcohol, not really use of opiates, but use of alcohol, and you feel that she doesn't have enough support and that her life is very stressful. So how to access CRS and what other suggestions might people have?
That's it exactly, yeah.
Okay. Any clarifying questions? We've got more things that we want to know about this person so that we can think about what suggestions we have later.
Kevin, I guess just logistically, in terms of sort of fitting some support into her life, obviously things sound super busy. Do you have a sense of what she might be able to do? Would this be to sort of do some sort of virtual connection to a CRS in the evenings, or do you have a sense of what might work best for her work and then her child care schedule?
Yeah, I think that's, I think the evenings would most likely work the best. I do think that she does have, periods of time during the week as well. She's a little bit of an irregular work schedule. Today she starts at 2. So I do think that there, would be other opportunities during the day.
more questions? What do you want to know about her?
Kevin, this is Angie. Thanks so much for the case. Just a comment, it's really helpful to hear her narrative after being incarcerated and how difficult it is to find a job after incarceration, and then not, this anticipation around your schedule and if you can juggle it, and the other barriers around like maybe transportation or other crises in our life. So I'm so it gives me hope that she was able to share that with you and your team, and you all were able to receive that and say, we're still here, and we hear the barriers that are preventing you from coming in when you're scheduled, and we're still worried about you and want to connect you, as you have capacity to do that. When you got on the phone with her, what was some of the main messages you heard from her, that you received from her after this absence of time and missing an appointment?
So no, there wasn't a lot, but I'm optimistic that there will be in the near future, because my message was really just, this year in drug screen, this is what it showed, and how can we help? And what can we do next? And my only interest is helping you in the best way that I can. And so I think she didn't really have a lot to sort of, respond to in the moment. I asked her, told her I thought a certified recovery specialist would be a good idea, and she was open to that. And that was sort of the end of our conversation. All the other sort of background was information that she and I have talked about in the past. So I think what's likely going to happen, especially with the assistance of a CRS, is that she'll know that that she can continue treatment here, and with more support have ongoing success. That's what I think is going to happen.
Mm-hmm. And has she made the appointment to come back in for the Vivitrol? Has she rescheduled that? She has.
Yeah, she made it 11 days ago, and she's we go whatever exactly it was, and she has scheduled the next appointment. So
have you thought about that interaction with her? And I'm wondering if it would be helpful to role play it. You be her.
Yeah, helpful to role play it?
Yeah.
Okay.
I don't know if it would be helpful. Have you thought about that interaction when she comes back after this time of absence? Where she's potentially let you down. She's let you down, right? She's been gone. Maybe her addictions reared its head, perhaps, right?
I think but I think what you've taught me, what Paige has taught me, what Jillian has taught me, and Abby has taught me, I don't look at this as her letting me down in any way. It's just, part of this condition, and this is what's expected. And so is there a way that we're not responding, helping her? Is there a need that's being met that we can help her meet?
Yeah, great. That's a really good question. All right. Well, I'm going to let other people ask questions too. And if we find that you wanted to do a role play, we might have time to do that too.
Yeah, we can do stuff like that on our virtual community. I wonder if our behavioral health folks have questions about this case. It's really so important to hear all the different perspectives.
I have just a general question. I know that a lot of the services and a lot of the resources are county specific, but being now that everything is being done virtually, can individuals in that area have access to the resources in other areas? Is that a possibility? Or maybe even volunteer resources? For example, like how Paige mentioned earlier about Sync Recovery. where it's not necessarily a paid service, but linking with like-minded individuals that that your patient can relate to.
Paige, do you have the website for Safe Recovery? Is it saferecovery.org, or how do you reach them?
Yeah, if you just Google Sync Recovery, it will.
SYNC.
We have a, yeah, SYNC. We have a Facebook page, calendar events. Sync runs the rally in the valley.
Mm-hmm. Beautiful. So that's a potential resource that doesn't have payment restrictions or geographic boundaries, which is wonderful. And I know was asking, we have a program through the PACMAT that'll be starting soon, and we're meeting on Friday to finish up the workflows to have a CRS available remotely from treatment trends to be able to serve some of the counties where it's been harder for us to figure out how to access. And then I'm hoping also that our caseworker folks, Sophia and Yamalisa, will be able to help us dig in a little deeper in some of the places where we don't know how to access those resources, as well as we do in Lehigh and Northampton counties, so that we can help more. And we'll be looking for our friends up in Lucerne County, and Bill, you may be able to help us out with some of that. And out in Monroe County and Carbon County too.
Yeah, specific to this, I from what I've seen, except for what Paige was talking about, I still think I think the virtual stuff is what's new, but I do think it's a lot of geographic boundaries by county. But if she reaches out to Council on Chemical Abuse, or COCA, which is really the SCA down there, I do know that recovery, I was talking to someone this week, they do have recovery specialists that are available and can be linked. So in terms of getting to the need as quickly as we may need to here for her, getting her wired through Council on Chemical Abuse, or just even if she puts an inquiry call there about getting CRS services, that might be something that that will help right away.
I'll try them again, Bill. I had another patient. I had, because I contacted them before, and they'd actually talked to us. That was Bernice who spoke to us a couple months back, and so I have the referral form that I for a different patient for a CRS, but they never got back to us. So I'll reach out to them again. I'm not sure why the connection's not.
Patricia, are you active in Berks County to some degree also, or no? I'm always a little fuzzy on where that line is.
I'm the CCT, helping out with those hubs. So yeah, anything that the embeddeds need help with, that's what I'm there for.
Yeah.
Patricia, what I'm going to do then is I'm going to put a referral, like we'll just follow this process that we haven't followed before because we had a sort of a separate, unique process with Gloria.
Yeah.
So now I'm just going to, what I'll do is I'll put that referral in and I'll send a separate comment that, connection, what this patient needs is connection to CRS or whatever else you think would be helpful.
Okay.
We don't need to role play this case. I'll just put the, maybe there might be other cases that we could talk.
Right, and anytime anybody says, oh, I really need help trying to figure out how to have that next conversation, I think that's a great tool for us to be able to think about. And what a nice little fishbowl style. Angie, are you, what I think I'm hearing is that that in this community where it's relatively new, that Kevin's practice has a budding relationship with COCA, and that the SCA there, Bernice, has actually reached out to Kevin's practice, I think for this patient even, to make that transition from jail to a primary care practice to continue the treatment with the Vivitrol. Is that right, Kevin?
No, this was this patient came to our practice. Really, it was someone who works here. One of our staff members made the connection because knew that I was doing that work. And I had reached out to the Berks Coca. They've been helpful for us for this naltrexone project that we were working on with Elise to get staff trained in naltrexone and to carry naltrexone. And then we reached out to them to, I reached out to them specifically about the CRS. So there's also insurance issues that, Berks Coca is really for medical assistance. So that's been part of the issue as well.
She has private insurance. It's such an interesting thing to me that, at neighborhood health centers, we kind of often are very much in the medical assistance world, our SCAs and so on. I think Layne and Lehigh County has been great at reminding us that it's also about the uninsured, and some of our privately insured folks almost look uninsured when it comes to some of these resources for substance use disorders and trying to navigate the medication world for them as well as treatment. It's pretty hard for some of the private insurances. They've been challenging prior authorizations. They often don't know what forms they want us to use. And so on. So it's challenging. And I think we do need our whole team approach. So Angie, what I was going to ask was if Patricia can kind of help start exploring what are some of these resources that we feel as a team are really, really important. But as you probably will hit roadblocks, Patricia, or weird moments of these things don't quite add up, or tuning that conversation, like Kevin just mentioned, that there are a lot of resources available until you find out what that person's insurance is. That come back to the hub to try and help us learn that and solve problems with you, right? So then the case managers, Sophia and Yamalisa and Angie, can kind of help think it through, and Stacy can help us, and Tom can help us sort of think through, like, where are the gaps? What are the things that aren't, that when you come right down to it, nobody has an answer for you about where to get a CRS today. Where are those gaps, and how do we start coming together as a system to close those gaps?
Yeah, most definitely. And Patricia, that certainly has happened, with another case that you've done, but Tiger Text as well is working for the team too. So anyway, you want to loop us in or you need help, we're here. And Kevin, I just want to say what you said at the end about communicating to her that these things are a normal part of the process. Like those exact words from you to her could be so powerful to the depth of your relationship. Because if you think about her trauma in the criminal justice system, what urine drug screens maybe likely have been connected to for her, returning to jail, violating probation, having her kids taken away, being uncompliant, right? And so just talking about a urine drug screen can be triggering, right? Can be like, what is he going to do? Who is he reporting to? And so laying the groundwork for what that information means to you in your care with her could really lay the groundwork for future discussions around what your role is in her care and how much it is going to likely be different than what she's received in other systems that maybe have been traumatizing to her. And so I think what you said at the end was so powerful, and maybe she doesn't know it, that that's how you feel.
Thank you.
Kevin, thank you for bringing an impromptu case. That's really wonderful. And we're getting close to time. I'd love to have a little bit of time just for a closing, a go around, and if we can just mention one thing that worked for you or was helpful for you today about today's session. We'll keep track, and a couple of things we tried differently today was the impromptu session, starting with a case and embedding that didactic in the middle. You know, we won't get feedback from the people who had to leave early, but hopefully they enjoyed having a case to chew on. So I'm going to go through my list, and we just have just one thing that worked for you for today, or that was a takeaway for you for today. And Valerie, I'm going to start with you again because you're on top.
Good morning. So I never knew what the ESIS was about. So that's something that I learned new for this morning. And also knowing that we have a whole team that can support each other in terms of connecting our patients and resources.
Sophia.
No, I think this is a great space to talk about cases and kind of bring a whole bunch of different heads together and problem solve. And I think, you know, the big takeaway message here is, you know, really focusing on meeting the patient where they're at and being able to support them and kind of help them build their narrative, and just having a bunch of information and being a support for them.
Wonderful. Lori.
I would say that the seeking safety information, just being trauma informed, I think all around is really important. So any additional information is always welcomed.
Kevin. Thank you, Lori.
So the just listening to you, I didn't know that Frank's case was going to be presented today. That was just such a great case. And just so, I mean, I was involved in the early part of it, but not you know, what transpired since. And it just gave me such I don't know, such a good feeling, and such you know, knowing that we're moving in the right direction. So thank you.
Thanks, Kevin. Paige.
As usual, I just am so grateful. It's the same thing every time we have one of these. I'm just blown away, and I'm so happy that everybody's on board and that this population, these patients, are getting what they need and deserve. So thank you to everybody.
Thank you, Paige. Culture change happening. You're the pioneer. Franklin. And do you like going by Frank or Franklin?
Either or. I'm fine with either.
I'm just curious.
What a great presentation from beginning to the end. The educational series. Learned a lot today. Really enjoyed the collaboration efforts and just how the network right now is really open to having these discussions. I think about the external, you know, the circumstance that led for this patient just to open up and to Dr. Esperanza. And, you know, it was a moment, it was a hidden agenda that she just took a risk to say, hey, you know, this is what's going on. And the invitation was accepted, and it led to this wave of support from the network. So I'm really happy that these things are happening. I just opened up Epic, and I may need to follow up. I didn't want to steal other people's time, but I do have a case that I might need help from you guys. Really quick, it's a patient at the Center for Women's Medicine Clinic at 17th Street who was in her early stages of pregnancy, I think 12 weeks. She did disclose she's using Percocet, about 30 milligrams a day right now. She's lowered it because of COVID and access, but afraid of withdrawal and miscarriage. We were trying to get her into the Connections Clinic at 17th Street, not really happening right now, with Dr. Flicker being more on the inpatient side, and they were trying to transfer her to Pond Road with Dr. Boyle, but transportation and getting there is a problem. She's Center City patient, no PCP, so I know there was just a message I got regarding maybe getting her connected to the neighborhood health center, Dr. Lecter. So maybe after this, I can follow up with you just to kind of brainstorm and see how we can get her into care, because she is worried about, she wants to treat the harmful substance abuse. She's open to it. She just wants to do it safely, and like to support her through her pregnancy at this Center for Women's Medicine Clinic. But again, thank you guys. This is great. I'm just happy to be part of this discussion.
Thanks, Franklin. We'll circle back. I've got some ideas, but it means somebody's going to have to accept that invitation too, and we'll see how that goes. But yeah, we'll come together to help her. Thanks for being part of our community. Judy.
Hello. Like I said earlier, it's really happy to be back and having these conversations again. It's a great reminder to, be empathetic to our patients, meet them where they are, and also to the providers and everyone, the team helping treat the patient, to just remind yourselves that you're not alone. It is scary, when you are sitting in front of these patients and going through your mind and trying to find the resources, to know that we have these meetings, that we can come back and share these patients and, have the team support to bring back to our patients. So.
That's great. Trisha.
As always, I'm just excited that everybody's working with the patients through the network, and that more and more of them are feeling comfortable, having the discussions and cases are coming up. So feeling good at the end of the meeting.
I love it when we feel good. Yamalisa.
Hi, everyone. So definitely today was a beautiful discussion. I love to see the growth of our team from last year to this year, getting over 30 on the call. So that's amazing. Love the didactic, but definitely the case coming first was great. Was a great shift, and I think it works really well.
Jillian.
I love that, Frank's patient has been receiving her care at this same setting for a very long time. And I feel like that is, if she was my loved one, I would want her to be able to receive this care, whole patient care, MAT, in that same place. And so I think it's a real testament to Frank. He sort of said it was because of his T-shirt, right? But it's his whole being, right? Who he is as a person, as a physician, that created that space where this woman could disclose what she had been going through. So I think that his case really kind of represents all that is incredible about integrating MAT and this work, whole patient care, into the primary care setting.
Beautiful. Drew.
Yeah, I've really appreciated the case coming first. That really activates me in a way that listening to a presentation at 7 a.m. doesn't. And I very much appreciate what Jillian said. I think that I want the group to know that, Neighborhood Health Centers of Lehigh Valley does provide, that whole person care, including for maternity care, so that patient Franklin might have a good place there, not just for treatment of her opioid use disorder, but potentially for her pregnancy as well. And that's something that we're really working on as a department in family medicine, is expanding the number of practices and clinicians who are doing more of that whole person care. So I'm glad that this can be a part of it.
Thanks, Drew. Bill.
Much like everyone else, the whole presentation was really good. I particularly was impressed by the case, and kind of what Dr. Jillian was talking about is it's really neat to know that no matter where that disclosure about substance use disorder happens, that we have a network response to it. We have an integrated, I love that word, we have an integrated response to it, and the patients really, once they have that conversation, they are going to receive care, and they are going to receive a great team effort. So just feeling real good and real positive about that, and just inspired to move on.
Thank you. Chris.
I appreciate the review of ACEs, but also I really valued the application of ACEs within the substance use. So I appreciate that. Thank you.
Great having you here. Layne, you still there?
I am still here. I enjoyed today's discussion greatly, and I love that even though people may not truly know all the steps, they now know who they can reach out to when they have a patient. And so the word's getting out, and I think that's fabulous.
Yunji.
Did you say Angie or Yunji?
They do sound the same, don't they?
Yeah.
Okay, yeah. Yunji, are you there? How about Gail?
Can you hear me now?
Yes.
Okay. Well, I had to jump off because God forbid we should have an hour without COVID for a while. But I love that the case started out. And I think the other thing that's valuable about this is how we talk about or how we talk to the individuals who share their lives with us. And that's really helpful to me always. Also, I'm happy that you record this so that I can get what I missed.
Great. Yeah.
That's it.
Thank you, Gail. Shall we try to unmute Yunji one more time? If you're there, Yunji, and you want to put something in the chat, I'll read it for you. I don't know why we can't unmute. Janice.
I thought that the framing using the cases was, I think it worked, and I enjoyed to be able to have two cases to discuss today, especially since it was an impromptu decision. I think the fact that it did look that like that shows, it speaks to kind of like the dynamic that we created as a team. So I appreciate it.
And Angie, did I miss you?
That's okay. No, you got me now.
You now, good.
Yeah, I think some words that are coming to my mind are just about community and all of the people that make this work possible, even the people that are working behind the scenes. You guys are all on this call and you make this work possible. Like every day, you're keeping us on task and connecting us. And so lots of gratitude to you as well. And I also enjoyed the case education case and made me think about patients first, community, education, and then coming full circle with it's always about the patients and who we're serving. So lots of gratitude to all the people that are coming into the community with open hearts and open minds.
Thank you. And I think the words for me, it's partly what Franklin was saying about that accepting the invitation. I think that's the piece that really is moving me today. And I had to sort of grab my heart when you said that, Franklin, because it was like, yeah, that's what it's about. It's about accepting that invitation. That people put stuff out there all the time. And I'm feeling this huge shift that this community of people here is starting to actually tune into that invitation and to accept it. And that's beautiful. And it's great to see that being this integrated group, and the partnership is what makes this really, really cook. So thank you for accepting invitations. Excited to see what invitations we'll all accept together next month at our next ECHO, which is which date?
17th.
June 17th, 7 a.m., same Zoom channel. And we'll send out a reminder. Sorry about some of the confusion of canceling and uncanceling and canceling. We're trying to get our system going, but if you want to present a case, that case presentation form is in the invite. You can fill it out and send it over. If it seems daunting to fill it out, I can do it the way we did it today. That's fun too. And the recordings and resources will be posted on the NHCLV Neighborhood Health Centers Project Echo page. And that link is sent out in the invitation as well. If you're looking for CME or CEU credit, please fill out the evaluation thing that will be sent out to you. We call that a survey. And then you can claim your credit. And we look forward to seeing you next time. Have a beautiful day.
Bye.
Bye, everyone.
Take care, all.
Have a great day.
Bye-bye.
Happy, did you want us to stay back to debrief?
I think that's a good crew. Hey, crew.
Can you guys, is Jazz part of the crew?
Yeah, she's here. She's
Great. Oh, great. That's you. Okay, sorry.
I did like doing the casework.
I did too.
Me too.
I'm just so grateful to Frank. I mean, I thought that we had sent him the template on Monday, but it didn't go out, and he didn't even have the invite until night. And still was like, yeah, sure, I'll do it.
That was great.
Really great behavior. It's like, yeah, that's. Yeah, what are other thoughts?
I think it was great that he was able to have a conversation with her, and it was the shirt that kind of was like, hey, you know what? I'm comfortable enough to say, like, I need help. And I thought that was really awesome that she didn't have the barrier of having to go into the office. She met him virtually. It was a little bit more relaxed. And I think that created the opportunity for that discussion to happen. So it was pretty organic. It was pretty cool.
Yeah. Yeah. And the part that he didn't totally mention was just the complete small town nature. He said there are people in his practice, the staff in the practice, that have known her since she's a baby. And so they were really excited about being able to do this for and with her too, which I think is just super sweet. It's very sweet.
Yeah, if you've never been in Emmaus, it's the most adorable little town. So yeah, they really like helping each other out there.
Well, that Southside practice has a really interesting history. And he hinted at too that one of the biggest prescribers of combined opioids and benzos was in that practice, but he was like a very fascinating, caring guy who had a lot of really complicated people, but couldn't make that transition from we should be giving everybody lots of benzos and opioids to we shouldn't be giving people lots of benzos and opioids. So the practice itself, I think, has gone through a lot of trauma of trying to make that transition in a safe and responsible way, and to see them coming to this point now is just kind of a really interesting moment.
Yeah. And Frank's a big leader in family medicine.
Yes.
So he has Dr. Spraza has a big voice in family medicine. So having him come to the table has more power. The waves of him showing up has more power than we maybe recognize. And Gretchen will be joining his practice, who is Wayford.
Yeah.
So it might just give her, the support she needs to prescribe Suboxone as well. So I love how the past two echoes, we've had these cases where the hub has been able to come together, the PACMAT hub, and help get these practices kind of going. And, there's a time where I wish in my mind, we can do this, come on, prescribers, you can do this, step to the table. But I think, it's happening organically. And these cases, I think, are exactly I feel like Frank sharing what he did at the end was, he wasn't sure if to do it or not. And it's almost like there's still uncertainty in the system as well, right? That this can actually happen. Am I giving my patients false hope? And the fact that he said, hey, I got this pregnant patient and this is it. And Dr. Keister says, let's talk about that. Family medicine wants to be that, not only for MAT care, but for pregnancy care. So, I think thinking about our response to Frank today to wrap around him and then coming back with that case, to see how that works out. I just think this echo is powerful. I'm so happy it stood up the way it has. You guys have done a phenomenal job.
On our little shoestring.
Yeah, I mean, at wrapping up last year, I know that there were doubts that we would be able to keep it going. So I think this is amazing. I love it. I think learning the faculty role for me over the last couple of echoes, as opposed to last year, because it was so few of us, it's like learning to just stay quiet and like sit on my hands as I'm like jumping, like, oh, I want to talk, I want to say. But it's like, no, let the participants. I'm doing it, Abby.
You were great. And then there was a point where I was looking at you, but you don't know that, right? And then seconds later, you jumped in. I was like, oh, she knows. I could have given you a clearer signal. Learning that one myself.
Private message.
Right. Well, and I did Jillian partway through that and said, do you want to take this one on the sort of how do you talk about Oxone versus Vivitrol when there's a stigma? How do you now navigate a healthy choice for somebody, and what's a choice that's based out of their fear of stigma? In this case was that, and I texted him at some point, I said, a lot of times our people, we haven't had a lot of success with people detoxing, getting through the withdrawal, and actually maintaining the abstinence. So I'm not sure that that's what happening for her, even though that's what she said. Be ready for who knows what. So he'd gotten that urine drug screen and there were no opiates in there. He was really excited, but he's like, but there's cocaine, so we can't do this, right? We're not treating that right now. We want to get that under control. And then let's and he, just that little tiny tweak, and he was fine. It was great to see that. For several years to do this, so all suggestions will make a big difference for him. Aren't a surprise, but to see that just little tweaks in the right direction for Frank helped him say yes. It's beautiful.
Yeah.
I was just going to say, I think Angie, you saying let's look at what she's doing. She's trying to self-medicate, right? Like she's trying not to use, but she's using something else in replace of that. So just having that kind of mentality, because I think with the doctor's side, they're looking at everything medically and we're looking at everything behaviorally and how they're trying to self-medicate and why they're trying to do that. So I think having that conversation really was a light bulb moment. So that was really awesome.
So how was the addressing the stigma language? And Frank used dirty a number of times. What is the faculty's thoughts on how we go about? Do you want, all of the echoes I've been on, we do it in a live version, but it also stings a bit as it comes out. And there's some reluctance to do it. There's an option to do it privately, but then you miss the educational opportunity that happens.
Yeah, I think I like the way that you did that, and then I wrote it down in the suggestions that are in his case also. And I think to me it was pretty gently done. I think I remember in the echo that I was in, Adam used to do it that way too. Making a general statement about it during the sort of suggestion period of how do we sort of, so easy to take a cue from the language that the patient feeds you. That's what we've been taught to do. But in some of these cases, we want to use different language and model that for people. And I think with Jillian in the webinar the other day too, she had an interesting one of people can use their own language, but that doesn't mean that it lands the same coming from us.
Right.
So having some awareness of that, and we wouldn't do that. Language that our patients will use in different kinds of moments, like we wouldn't do that. Right?
Right.
Yeah, I mean, I think the way you did it was great. It was beautifully done. It was very gentle. And like Abby's saying, you know, our clients will use the language, and I think it's just bringing awareness to us as a professional when we're standing in that environment, is knowing that they have access to certain words that are absolutely acceptable for them to use among themselves on their own. But then just us, you know, utilizing and getting used to different words. Because for example, like when I provide treatment, whether it's running groups or individuals in Spanish, there really is no kind word. We're using dirty, we're using clean. Like that's what's going to happen, just because we are speaking with individuals that you know, are very street language. That's their everyday. So it's accepted differently. So it's just really knowing how to address it. I mean, I can tell them, oh, you're sober today, and they'll be like, what's that? You know, oh, you mean I'm dirty? Okay. Because in Spanish it's just different. So I think we have access to a lot of different words, and like I said, the way that you did it was perfect, because we're able to do that in English and say it gently in English, and teach them how it's not a negative thing, it's not a failure, it's not, you know, it's all of those things. It's encouraging the fact that she had the courage to even bring it up, even though it was spur like, actually, let me tell you this. I think that was beautiful. I think that relationship, it's just so many positives from today. So
Thank you.
Cases too. I loved you holding up the seeking safety book. I'm hoping that we get a lot of opportunity to keep bringing up the seeking safety, and how can you integrate even a tiny piece into a primary care session for the behavioral health folks. How the
Yeah, you're cutting in and out, Abby. I don't know where your headset is in the room. Is that?
It's way over there.
Oh, that's better.
I'll look that way.
Look so over here, yeah.
Oh, good. Yeah, I think the seeking safety, you know, from some of the feedback, it seemed like it did resonate. And I think that's something that, you know, I've often thought, like, you know, we wrote seeking safety into the grant to do at the residency locations at BMC. BMC has either dropped off at some of our residency locations because of COVID, or is happening virtually. But I've been thinking, like, what are some other creative ways, you know, to get seeking safety going in the grant amidst COVID? I haven't come up with anything because we can't violate copyright, right? Like I can't like send pictures of the manual, and, you know, we don't have, you know, I think maybe, yeah. So anyways, if you have any ideas around that, we have seeking safety written in the grant as something we were going to pilot at the residency locations. But with COVID, all of that has transitioned, and I don't think we have a virtual group format in our Epic Haiku. I haven't heard any of our providers doing a group session in Epic.
You know, for the precepting, they're able to have more than one. They're able to do a group video, something or other. So I think they can do a group that way. But I'll check into that. I can ask Drew probably.
Okay.
And that might make it interesting that maybe we could have this little group right here. Do a seeking safety group that could bring together some of the early patients. And do they have a manual in Spanish? Do you know? I didn't see it.
I don't know. You know, it's out of UNM. I would think they do. Let me go. I feel like I read something when it was coming out, but maybe that's just off the top of my head. Let me dig around, okay?
I also thought it was interesting that, sorry, I didn't mean to interject, but that there were a couple of people that didn't know about ACEs, and I just kind of assumed like everybody knew what ACEs was and knew the kind of relationship of, you know, drug use as a way of coping or as a way of avoiding or of a way of self-medicating. And we may have blown a couple of minds. I thought that was kind of neat. So.
I find myself really the same, like, oh, everyone's heard of this, right? Like we're like 25 years post the initial. So yeah, it's always like humbling for me to hear that as well. Like this education is still really important. Why these scores are important. I think that's what I get from the residents a lot too, is like, then what? Like, okay, I get an A score, then what? Right? It's like they want, and it's like, that tells you a story, and, you know, and allows you the space to make some predictions about what could unfold in their narrative over time as you build this relationship. But yeah, I felt the same when somebody said, oh, that was new. It's like, oh, that's great.
Yeah, I did like also that you included just being mindful that some questions don't address a lot of the realities for our patients in, you know, urban settings, like especially Allentown and, you know, where we're at, you know, out of the Lehigh Valley. So it's important to just kind of read a little bit deeper into the questions and let them know that it may not state this in the words, but this is, you know, that's part of it. You know, parent issues, shootings, you know, whatever may be going on, because they're definitely vague questions. So that was great.
The other resource, and I mentioned in the chat that the website is the Urban ACEs, the one that Philly developed and uses, that has a couple of things that address that more. And I think Chicago used the Urban ACEs also, and gets a little bit for the poverty, inner city kind of issues and the inner city violence. And Promise Neighborhoods has been using the Urban ACEs in their community survey that the community health department does with them every year. So we have a little bit of data from Senate City, Allentown about the Urban ACEs. So that might be kind of interesting to follow up with. Cool. All right. I am now multitasking, which is a bad sign. And just writing multitasking as I text Drew back and say, oh, I didn't notice what time you said because I'm multitasking.
When you, Abby, when you reach out to Frank, what are you going to do? An email or a Tiger text? Just loop us all in.
Yeah. I'll do it as a Tiger text. But I'm going to start with Drew because actually NHCLV has not been very willing to do the prenatal care and MAT. It's a source of frustration to me. So what I might suggest to Drew and Mary is, can Pia do that at the Family Health Center? She's certainly really comfortable with both. And if they're willing to kind of let her get started, that'll still count as a PACMAT case for us, so that's fun. But I think that might actually be a better place, and possibly what we could be thinking about is if Amanda isn't able to do the connections clinic at CWM, can Pia do it?
Yeah, and have a connection with Amanda. We can loop her in to support the pregnancy, like just support it, the complexities with the MAT. Yeah, no, I mean, what a case to start with at the FHC.
But, and Angie, you know that Pia trained at UNM. So she was at.
I didn't know that.
So she did her OB fellowship, her family medicine OB fellowship at the University of New Mexico. And her population, she managed pregnant women with Subutex.
Oh my gosh. So she practices on the days when I'm there. I'm sorry if I'm cutting you off. I can't fully hear you. And then I see your lips moving. So, okay. So she does practice. She was practicing on on Thursdays when I was seeing patients. So that actually might line up for us.
Right.
Has she been on our call before?
She has not.
Okay.
She's at NHCLV one half a day a week, or was until the COVID stuff. And she's at the Family Health Center. I think because the Family Health Center isn't doing the prenatal care yet, we need to kind of hook her up with CWN. But if she's there periodically, she could do it there. So we can think about how to help make that connection. And can we just have her get seen for the MAT alone first? Because maybe Mary will, all these little things of how do you make the complicated pieces line up.
Yeah, no, but I think right now with COVID, this case is not gonna be unique.
Right.
It's just considering the fact that there will be a lot of pregnancies and there are a huge number of relapses or even new starts, being locked in the home with kids going crazy, or whatever situation is going on. So pregnant and opiate dependent is going to be a lot more common in the next couple of months.
Yeah. And I have one other thought. That case in Berks County, we need to figure out, Sophia, if the GIPRA was done from Karen, and if not, make that phone call with the paper version to get that GIPRA done.
Okay.
Yeah.
How do you want to address that? Do you want me to reach out?
Yeah, I'll start an email and I'll attach you to it.
Perfect.
With Tom and Karen, who did the behavioral health linkage post the session. And we need to, if you could just on the back channel figure out if you have Epic. Look in your SSO apps for something called Epic Hyperspace.
I do have it. I can probably look it up. I don't have it on this computer because I'm actually on my Mac, but I can do it on my work computer.
Great. So see if you have that and you can get logged into it, and then we'll schedule a time to play around in Epic with the .pacmat phrase, just so you can learn how to go in and look at MRNs and see what was done in that PACMAT note.
Okay.
And this is not related to the ECHO, but it is related to all of you. So I had a good conversation yesterday with Betsy from Mars, because we're doing another one of these small community grants with Mars. And part of what Layne Turner wants them to do is expand host to the primary care practices that are at least in Lehigh and Northampton County, so they would be able to do the GIPRA and the level of care assessment. So we're talking about that. And I mentioned that, Melissa, you were going to be, short-term part of this whole thing too, and how exciting that is. Particularly for our Spanish-speaking patients, will be, this mini grant will be helping to support the transition that the Hispanic program has made toward the virtual space. And Marlene Gonzalez is going to be working on this one. And her part will include a little practice improvement project, qualitative, we aren't calling it research, to check in with the people who are clients in the Hispanic program, just to get their experience with the virtual, helps them participate and what's in the way. Because I don't think we're getting very much information about what that's like in the drug and alcohol or primary care world from that point of view. So that's going to be kind of happening. I think that the Promise Neighborhoods is doing a Health Equity Institute with some students over the summer, and one of them is Spanish speaking. So she, I think, will be able to do those interviews, but and Diane's going to help mentor Marlene for the scholarly inquiry piece.
Awesome.
But that's kind of happening, and I think that's a space where Yamalisa, you can help us.
Absolutely.
Glue together.
Yep.
Yeah, that's good information. Close some gaps. I think you were talking at me. Sorry. Yes.
That's just information.
Oh, good stuff, Abby. Good stuff. Yeah, I think that there's certainly gaps in that population and how we better serve there in our primary care. So, all right. Yamalisa, June 1st.
Yeah, that's what I heard from Stacy.
You didn't hear that from the recruiter from State. Oh, Stacy, the recruiter.
No.
Or Stacy Cook.
Cook.
You didn't hear that from the recruiter
I don't think so. I mean, there's something in there about things being due by the 1st, but it wasn't clear that that was the official start date. And then Stacy was like, "Hey, I think it is." So I was like, "Okay."
Yeah. So Sophia, when did you get notification about like orientation and navigation, like about that communication? Like everything was, I feel like there's a point where they say, we've got everything, you're cleared for orientation.
Well, everything is done.
Okay, so you got that.
Yeah, so all the clearances, all the physical, everything is done. I think there's only one questionnaire left by my endocrinologist that they lost, by the way. So it has to be resent by health again. But I mean, it's ready. Let me see. Curvacy, important information. It says connections date 6/1.
Yeah. So
but I don't know what connections date means.
Oh,
is
that's
that
orientation?
Okay. All right. Then
so,
yes.
Do you want to tell Yamalisa a little bit about what that looked like virtually? I think I got notification that that's still happening, like how that process worked for you, Sophia.
Oh, sure. They condensed like a whole day to 3 hours, so that was kind of good. It was done virtually. It was a WebEx call, and it was actually really great. I learned a lot, so I thought it was really cool. And then the second day is navigations, and that kind of goes through, you actually go to a site and they check your temperature, you wear a mask, and that's a full day. But definitely interesting. You learn a lot there as well.
Awesome. Is there a start time?
I believe it's 9 to 12 the first day, and then the second day it's 8 to 4:30 or 8 to 4 or 5. So you get fitted for an N95 mask, all that fun stuff.
Did you get an email about the schedule from Connections or from the recruiter?
It might be in the body of the email, but I think there's like a web link that kind of tells you what the orientation schedule is. And, you know, of course, like when I was doing it, COVID was happening. So I think things were changing so quickly. It might be different for Yamalisa.
Mm-hmm.
So it maybe came, you're thinking in like a link in the email from the recruiter?
Yes.
And then it took you to the Connections. Okay.
Mm-hmm.
So if you can get because it sounds like Yamalisa, you're trying to figure out what time, where, all of that, where and when of June 1st, right?
Yeah. So I'll reach out to Stacy Curvacy. So she will be the one to provide me that information, because this email is almost 3 weeks ago. So it was right at the beginning when all the paperwork was being done. I haven't really received anything else from her. I've been in touch with Patricia from HR, just to, like, confirming that she's received everything that she needs.
Yeah. I was one of those really annoying new people, so I would email Patty all the time, and I would call Stacy, and I was like, I just want to make sure you guys have everything. Where are we at? And they were really great and responsive. So, you know, don't worry about it. I would just reach out.
Yeah, let's see. You can attach me to Sophia. So if there's something that if I can help you with, not Sophia, Yamalisa, if I can help you with it and connect, and that will pretty much be it. That'll take up your whole first week, is those trainings. Me and you will touch base too, just so we can plan out like a little bit about what your schedule will look like, so we know at the hub, so we're not just bothering you and pinging you at random times that
I need to know ahead of time. I gotta settle the kids.
Yeah. So we'll need to talk about that, like what your part-time hours work, what works for you. So I know when you're available and when and how to connect people to you when things get up and going.
I think Abby needs to step off. Sorry, go ahead.
We need to give this room back to NHCLV because they have, we have training and people are looking for spaces to be. And so we got to get out of here.
Bye, everyone.
All right, I'll see ya.
See ya.
Wait a minute, you can't just have a whole meeting here.